Welcome, everyone. Today, we're jumping right into a super strategic masterclass on all things hepatobiliary for the TUS. Look, our goal here isn't just to list a bunch of facts. It's to build a rock-solid mental framework so you can absolutely crush these questions, especially when the clock is ticking. You know that feeling, right? You get this long case, a dozen different lab values are staring you in the face, and you're just thinking, okay, where do I even begin? Honestly, it can be totally paralyzing. So here's our game plan. We're going to start with enzymes, then build a simple algorithm for jaundice. We'll demystify that crazy hepatitis serology, hit the high-yield systemic diseases, cover cirrhosis, and wrap it all up with a concrete strategy you can literally use on exam day. Let's get into it. Okay, first up, enzymes. I'm telling you, the secret to cracking any lab report isn't about memorizing every single normal value. It's about understanding why an enzyme is high in the first place. And the answer, my friends, is always location, location, location. Just look at the difference here. It's so important. ALT is pretty much a liver-specific enzyme, and it lives in the cytosol. But AST is different. It's in the cytosol and the mitochondria, and it's found all over the body. This one little distinction is the key to pretty much everything we're about to discuss. Exactly. That is the classic TUS question, isn't it? We all hammered it into our heads. AST to ALT greater than 2 means alcoholic hepatitis. But why? This is where knowing the mechanism saves you from just blindly memorizing. And here is the why. Alcohol is a direct mitochondrial poison. It messes up the mitochondria specifically, which then releases that huge mitochondrial pool of AST. That's why AST skyrockets compared to ALT. So the takeaway is simple but powerful. When AST is way higher than ALT, you have to think about mitochondrial injury. Alcoholic hepatitis is the poster child for sure, but don't you dare forget toxic or ischemic injury and Wilson's disease on exam day. Great. Now let's move on and see how these concepts build on each other. Jaundice can feel overwhelming, with a crazy long list of possible causes. But if you have a system, a step-by-step approach, you can cut through the noise really fast. Here is your algorithm. I want you to burn this into your brain. Every single time you see jaundice on the TUS, this is what you do. First step is the bilirubin indirect or direct. If it's indirect, your brain should immediately go to hemolysis or a conjugation problem. If it's direct, your next move is always an ultrasound. Then you ask, are the bile ducts dilated? If yes, you've got a blockage. If no, the problem is inside the liver itself. It's that simple. Just follow the steps. And this table right here, this is pure gold for the TUS. It's the hereditary bilirubin disorders. Just notice the beautiful pattern. Gilbert and Krigler-Nagar are indirect bilirubin issues, problems with the UGT enzyme. On the flip side, Dubin-Johnson and Roeder are direct bilirubin issues, problems with secretion. And of course, you absolutely cannot walk into the exam without knowing the #1 buzzword for Dubin-Johnson, the black liver. An excellent point. Now you're thinking like a top scorer. These are the details that get you the extra points. You're spot on. In Dubin-Johnson, because of that secretion defect, you can't see the gallbladder on an oral cholecystogram. But in Roeder syndrome, you can. That's a fantastic next-level detail to have in your back pocket. All right, deep breaths, everyone. Let's tackle the topic that I know causes a lot of anxiety, hepatitis serology. I know it looks like a confusing alphabet soup, but trust me, once you understand what each little piece of the puzzle means, it all becomes perfectly logical. Let's just break it down nice and simple. HBAG, the surface antigen, means the virus is actively there. You have an infection. Anti-HBs, the antibody to the surface antigen, means you're immune, either from a vaccine or recovery. Now, the core antibody, anti-HBC, tells you about timing. IgM is for an acute, recent infection, while IgG means past or chronic. And finally, HBAIG is your go-to marker for high viral replication and high infectivity. See? Not so bad. Now, let's talk about a classic TUS trap. They love this one. They'll give you a patient, and the only positive marker you see is anti-HBC IgM. So what on earth is going on? This is the famous window period. The surface antigen is gone, but the protective surface antibody hasn't shown up yet. That anti-HBC IgM is your only clue that this person has an acute infection. They love to test this. Another fantastic high-level question. The Precore Mutant. This is a tricky one. It's a version of the virus that has a mutation, so it just can't make HBAG. The lab results look really weird. The patient is HBAG negative, which should mean low replication,
but then you look at their HBV DNA and it's through the roof. This is a dangerous, active chronic hepatitis that needs treatment, and it's a favorite toss crossball.
Okay, let's switch gears to two systemic diseases that are pretty much guaranteed to be on your exam. For these two, it is all about recognizing the classic cluster of buzzwords in the case vignette. When you hear hemochromatosis, I want your brain to just scream iron. The case will almost always give you that classic triad: cirrhosis, brand new diabetes, and that bronze skin pigmentation, what we call bronze diabetes. Also, keep an eye out for arthritis, specifically in the second and third MCP joints. Labs will show super high ferritin and transferrin saturation. And the treatment? Simple, phlebotomy. And for Wilson's disease, you guessed it, think copper. This is usually a younger patient who shows up with liver problems plus some weird neurologic or psychiatric symptoms. The absolute dead giveaway, the pathognomonic sign, is Kayser-Fleischer rings in the eyes. Key labs, low ceruloplasmin, and sometimes you'll even see a Coombs negative hemolytic anemia. Treatment here is with copper chelators. All right, moving into our last big clinical topic. When it comes to cirrhosis on the TUS, the questions are rarely just about the diagnosis. They're about what happens next, prognosis and management. And knowing which scoring system to use in which situation is absolutely critical. First, just a quick reality check on the causes. Yeah, worldwide, Hep C is the big one, but you're taking the twos, so you need to know the local context. In Turkey, hepatitis B is still the most common cause of cirrhosis. And of course, NASH is just exploding everywhere and catching up fast. Now, this is a huge point for the exam. Child-Pugh versus MELD. When do you use which? Think of it like this. Child-Pugh gives you a general prognosis, a sense of survival, and it includes some subjective things like ascites. MELD, on the other hand, is purely objective labs, bilirubin, creatinine, INR, and its one and only job is to prioritize patients on the liver transplant list. Okay, let's pull all of this together. We've gone through a ton of material, I know, but honestly, more important than any one fact is having a system for how you attack these questions every single time. This is it. This is your 4-step plan. Number 1, always start with the why, the mechanism. Number 2, picture the patient in your mind. How would they look? What would they say? Number 3, become a detective and hunt for those classic buzzwords like the Kayser-Fleischer rings or that black liver. And finally, number 4, actively think like the examiner. Where are the traps? Is this a window period? Could it be a Precore Mutant? That is it, 100%. The entire point of this session wasn't to just dump more facts on you. It was to give you a clinical reasoning framework. Because if you can think through the mechanism, you can solve questions you've never even seen before. You have the tools. You have the strategy. By focusing on why things happen instead of just memorizing what happens, you're not just studying for a test. You're learning to think like a real clinician. You are absolutely ready. Good luck.